Coming to CVS or cardiovascular system, this is a pretty big chapter because in cardiovascular system you have drugs to treat angina, congestive cardiac failure, arrhythmia, hypertension. There are a lot of drugs. So let's see whatever is more important and give more stress on those areas. The first condition that we'll discuss is CCF or congestive cardiac failure. What is congestive cardiac failure? Here, heart is unable to provide adequate blood supply to meet the oxygen demand of your body. The pumping ability of the heart is reduced and therefore there is low cardiac output. There is low cardiac output, so there is no proper oxygen supply to your body, and this condition is known as congestive cardiac failure. There are two types of failures. One is low output failure and one is high output failure. In low output failure, the cardiac output itself is low. Examples are ischemic heart disease, hypertension, valvular and congenital heart diseases. Here the cardiac output is low and you have a congestive cardiac failure. In high output failure, the cardiac output is high but still the body's oxygen demand is not met. Such conditions are anemia, even though there is volume, because of the less number of or less amount of hemoglobin, body's oxygen demand is not met. Similarly, thyrotoxicosis, beriberi, and in certain congenital heart disease also it is high output failure. So what are the drugs that we use to treat CCF? Three group of drugs we'll discuss: cardiac glycosides, vasodilators and diuretics. The cardiac glycosides or digitalis group of drugs are digitoxin and digoxin. They are both obtained from the plants of the foxglove family. Among these, digoxin is more commonly used because digoxin has more favorable pharmacokinetic properties. They have positive inotropic effect or they are cardiotonic drugs, meaning to say they increase the force of contraction of the heart. So the ventricles are more completely emptied because of this forceful contraction. But these drugs have a low safety margin and they have many adverse effects. Arrhythmias like extrasystoles, bradycardia, pulses bigeminy, all these can be caused by cardiac glycosides. Ventricular arrhythmias can be treated with IV lignocaine. The common anesthetic solution we use as LA. Lignocaine is given IV to treat ventricular arrhythmia. Bradycardia can be treated with atropine. We already know atropine can increase the heart rate. So bradycardia can be treated with atropine. Supraventricular arrhythmia can be treated using propranolol. We can also use phosphodiesterase inhibitors or PDE inhibitors like ambrinon and milrinone. They inhibit, from the name it is clear, inhibit phosphodiesterase. Phosphodiesterase usually degrades cyclic AMP. So when this is inhibited, cyclic AMP levels increase. Due to this, there is increased force of contraction. There is also vasodilatation. This is not preferred. Coming to vasodilators, nitroglycerin and isosorbide dinitrate are vasodilators with rapid and short action. Among these, sodium nitroprusside is a powerful vasodilator because it can dilate both arterioles and venules. After vasodilators, we have diuretics. Diuretics are drugs that induce diuresis. So the three group of drugs coming under this are thiazides, loop diuretics and potassium sparing diuretics. First is thiazide diuretics. Thiazides block the sodium chloride co-transport system in the early distal tubule. We know for every glomerulus in the kidney there is a PCT or proximal convoluted tubule, a loop of Henle and a DCT or distal tubule. So this sodium chloride co-transport is blocked in the distal tubule so that the sodium excretion is enhanced, and along with sodium, water is also lost from our body, and that is how diuresis happens. Coming to loop diuretics, from the term itself it is clear it acts in the loop of Henle in its ascending limb. Here also the sodium chloride reabsorption is inhibited, meaning to say this will be excreted. As the excretion of sodium and chloride is increased, water is also lost. That is how loop diuretics act. Coming to potassium sparing means the loss of potassium is spared, or potassium is spared, it concentrates on the sodium. So aldosterone is a molecule that enhances sodium reabsorption. The potassium sparing diuretics inhibits aldosterone, therefore sodium reabsorption is inhibited or more of sodium is lost. Along with that, water is also lost or diuresis happens. After drugs for CCB, let's see antihypertensive drugs, meaning to say the drugs that are used to treat hypertension. There are many group of drugs which are involved in treating hypertension. Let us see all the groups. The first group is diuretics, which we just discussed. There are three groups: thiazide diuretics, and the examples are hydrochlorothiazide, chlorthalidone, and indapamide. These act on the early distal loop, distal convoluted tubule. Then we have loop diuretics, which are furosemide, bumetanide, and torsemide. The mide and nide drugs are loop diuretics acting on the loop of Henle. Then potassium sparing diuretics, which spares the loss of potassium and inhibits aldosterone and act as a diuretic, are spironolactone, amiloride, and triamterene. These are the potassium sparing diuretics. The second group of drugs used as antihypertensives is angiotensin converting enzyme inhibitors or ACE inhibitors. These are prill drugs: captopril, enalapril, lisinopril, ramipril, perindopril, fosinopril. All the drug names ending with pril are ACE inhibitors. Then we have angiotensin 2 receptor antagonist. These drugs are losartan, candesartan, valsartan, eprosartan, irbesartan. So what did you notice in common? Sartan drugs ending with sartan. Then there are sympatholytic drugs acting as antihypertensive, and these sympatholytic drugs can be of four types. One is centrally acting. The examples are clonidine, methyl-dopa, guanabens, guanfacine. Ganglion blockers are trimethophan. Adrenergic neuron blockers are guanethidine and reserpine. Adrenergic receptor blockers are alpha blockers, beta blockers, and those blocking alpha and beta receptors. First is alpha blockers, which we have already studied in the sympathetic system: prazosin, terazosin, doxazosin, phenoxybenzamin, phentolamine, such drugs. Beta blockers also we are familiar: propranolol, atenolol, esmolol, metoprolol. Then those which can block alpha and beta are labetalol, carvedilol. The fifth group is calcium channel blockers. Calcium channel blockers also act as antihypertensives. They can be verapamil, nifedipine, then amlodipine, nimodipine. These names are familiar: nicardipine, felodipine. Okay. And finally, vasodilators. Vasodilators can be arteriolar dilators or a combination of arteriolar and venular dilators. Arteriolar dilators are hydralazine, minoxidil, and diazoxide. And thus, the drug which can dilate both arteries and veins. Arteriolar and venular dilator is sodium nitroprusside. Now let's see the mechanism of action of each of these. Diuretics we just discussed. They can induce diuresis or loss of water, and they can act as antihypertensives. Then angiotensin. It is clear from the term. Angio means blood vessel, and tensin or tensing means giving pressure. So angiotensin gives pressure on the blood vessels. So let's see its mechanism. Angiotensinogen is a precursor on which renin acts, and it is converted to angiotensin 1. Then ACE or angiotensin converting enzyme is involved in converting angiotensin 1 to angiotensin 2. So angiotensin 2 is the one which is involved in producing the effect vasoconstriction. We already said angiotensin means it tenses the blood vessels, or it constricts the blood vessels and increases the BP. Then angiotensin 2 gets converted to angiotensin 3, and angiotensin 3 can lead to the formation of aldosterone, which can increase the salt and water retention, and which can again contribute to rise in BP. So this is how the blood pressure in our body is maintained by the renin-angiotensin system. So our second group of antihypertensive drugs, the ACE inhibitors, is involved in inhibition of this ACE enzyme or angiotensin converting enzyme. Ultimately, it doesn't allow the formation of angiotensin 2, or there is no vasoconstriction, so there is reduction of BP. So ACE inhibitors are the pril group of drugs. Example is captopril. Next is ARBs or angiotensin receptor blockers. So even though angiotensin 2 is formed, it has to act on its receptor to bring about the effect of vasoconstriction. So if receptor is blocked, again there is no increase in BP, so they can be used as antihypertensives. Angiotensin 2 receptor blockers are sartan group of drugs like losartan, candesartan. Coming to the sympatholytics, the first group is centrally acting drugs. So clonidine and methyl-dopa are the examples. They are alpha 2 agonist in the central nervous system. They decrease the sympathetic outflow and bring about a fall in BP. Now look at the figure. Where can the next block come? That is the adrenergic nerves must transmit the neurotransmitter noradrenaline to regulate the BP in the blood vessels. So if we can block the adrenergic nerves and we can deplete the stores of noradrenaline, that can be used as an antihypertensive. So such drugs are guanethidine and reserpine. Guanethidine and reserpine are blockers of adrenergic nerves, or they deplete the stores of noradrenaline. The next is in the ganglia level. We have sympathetic ganglia. So this ganglion blocker is trimethophan. There is only one example, trimethophan. And finally, at the blood vessel level, the arteriolar dilators are minoxidil, diazoside and hydralazine. So all the drugs you will get from the figure. One is centrally acting, then we have at the adrenergic nerve level, then ganglion level, and finally at the blood vessel level. Two important questions that can be asked from the antihypertensive part is, which antihypertensive is safe in pregnancy? So methyl dopa is the one that is centrally acting one, is safe in pregnancy and it is used orally for maintenance of BP. And which drug is to be given for the reduction of BP in an emergency? It is hydralazine, and obviously for an emergency it is parenterally administered. The next group of drugs that can be used as antihypertensive is calcium channel blockers. The classification of calcium channel blockers goes like this: dihydropyridines and other drugs. The dihydropyridines are the commonly used one. These names end with dipine, nifedipine, nicardipine, nimodipine, amlodipine, felodipine, isradipine. You must be very familiar. So these are the calcium channel blockers. And the other calcium channel blockers other than dihydropyridines are verapamil, diltiazem and pepridil. So calcium channel blockers blocks the calcium channels in the blood vessels and they act as arteriolar dilators. Coming to the anti-arrhythmic drugs or drugs used to treat arrhythmia. So there are 4 classes of drugs. How do we remember this? There is a rhythm for any chant, right? So some bad people chant is your code. Some bad people. S is for sodium channel blockers, that is class 1. Class 2 is beta adrenergic blockers, which you have to connect with the bad. Class 3 is potassium channel blockers, your acronym is people, and class 4 is calcium channel blockers, and chant stands for that calcium channel blocker. So some bad people chant sodium channel blockers, beta blockers, potassium channel blockers and calcium channel blockers. Sodium channel blockers are your local anesthetics like lignocaine, procainamide, and the anti-epileptic phenytoin is also a sodium channel blocker, as you might know. Class 2 are beta adrenergic blockers. Obviously, you are familiar: propranolol, acebutolol, esmolol, etc. Potassium channel blocker example is amiodarone. Calcium channel blocker we already saw in detail. So calcium channel blocker examples are verapamil and diltiazem. Since sodium, potassium, calcium, all these ions are involved in maintaining the rhythm of your heartbeat, the blockers of these can be used as anti-arrhythmic drugs. We will finish CVS drugs with the last topic, drugs used in angina and MI. So you know what is angina? Angina is a symptom of insufficient oxygen supply to the heart. When the oxygen supply to the heart is reduced, heart manifests severe pain. This is angina, and as this is prolonged, this insufficiency of oxygen is prolonged, there occurs ischemia of the cardiac tissue, and this is myocardial infarction. So there are 2 types of angina, classical angina and variant or Prinzmetal's angina. What is classical angina? It is a stable angina. That means the pain is induced only by exercise or an excessive emotion, both of which can increase the myocardial oxygen demand. So only on physical or mental exertion, when the myocardial oxygen demand increases, the patient will experience a pain. Variant or Prinzmetal's angina can occur at rest also. When the patient is relaxed and calm also, angina can occur, and it is due to the spasm of the coronary artery. So these are the drugs that can be used. By now you know the mechanism of action of most of the drugs. We will just put together all these drugs. The first group of drugs that can be given are nitrates. You are familiar, when a patient suffers from angina, we can give them sublingual nitrate or sublingual nitroglycerin tablets. So nitrates, all the names will have nitro or nitrate in them. Nitroglycerin, isosorbate dinitrate, isosorbate bononitrate, pentaerythritol tetranitrate, all these are vasodilators, and this dilatation can reduce the workload of the heart. Again, calcium channel blockers like verapamil, diltiazem or amlodipine or nifedipine. Beta blockers like propranolol, atenolol can also be used as anti-angina drugs. A new group of drug may be potassium channel openers. Even potassium channel opening can lead to efflux of potassium and hyperpolarization, leading to a relaxation of the vascular smooth muscles. So it acts as a arteriolar dilator basically. Example is nicorandil. So potassium channel opener nicorandil can be used as an anti-angina drug. And miscellaneous drugs that can be used are dipyridamole, aspirin and trimetazidine. That was about stable angina. Now about unstable angina, we already know it is due to a blockage or spasm of the coronary artery. Therefore, we have to give aspirin because any platelet aggregation could have occluded our coronary artery. So this aspirin 75 to 300 milligram daily has to be given to the patient. This is to treat angina as well as to prevent MI. Next is heparin. Again, in high-risk patients, IV or subcutaneous heparin will lies any clots and this can reduce the pain. Nitrates, just like you have given in stable angina, you can give in unstable angina, and other drugs like beta blockers can also be given. I want you to be also aware about the drugs that should be given in MI. So MI, the patient is going to experience severe unbearable pain. Therefore, you have to give an analgesic like 10 gram morphine or pethidine intravenously. So this relieves the pain and reduces the anxiety of the patient. Next is any thrombolytic like streptokinase has to be given. We can also give aspirin. 300 milligram of aspirin can be given. This is also to effect thrombolysis. Then we already know the heart is suffering from decrease in oxygen supply. So oxygen has to be given. High flow oxygen should be given by inhalation. Then the MI attacks can cause nausea and vomiting. Therefore, antiemetic may be given. And finally, arrhythmias are very common in acute MI. Therefore, antiarrhythmics can also be administered. I think you're clear.